That's great. I'd open the floor up to questions now. There's microphones dotted around. Don't be shy. There's 2 at the front here and 2 on the middle row. So if anybody's got any burning questions, I'd welcome them to come down and ask. In the meantime, while you're all thinking and plucking up courage, I'll ask one of my own. One of the things, and it's probably to both of you, in terms of the wounds that you see that are chronic and have got lots of bioburden there and harsh wound environments, does excess protease or infection dilute the product or break the product down?
Well, I can at least answer for the harsh wound environment. So, of course, in these chronic wounds, there's a lot of proteases there that chops up everything that's proteins. But the beta-glucan is actually a polysaccharide, so it's not affected by these proteases. So it will sustain or have the therapeutic effect, even if in these harsh wound conditions. As for infection, this is also something that can drive these macrophages to not functioning optimally. But we do, and it would create a lot of noise for the macrophages. So we do recommend for infected wounds that you treat with an antimicrobial for a couple of weeks before you start Woulgan. And I don't know, Kim, if you had any...
Yeah, I've used it in sort of in conjunction with antibiotics on a patient, and I've not had any ill effects at all. Yeah, so I think that's something maybe we probably need to just work on a little bit more and just see generally what the outcomes are. Yeah.
So I suppose we've had this conversation outside of the room and in today about whether you should wait for the 4 weeks to start. I mean, that's always been my practice when we're adding adjunctive therapies in, but what's your perspective on whether you should start at day 0 or should we be starting at week 4, sorry?
I mean, for me, probably most of the patients actually have already been somewhere before, so the wounds may have been in treatment room for a little while and then they come to me. Sometimes podiatry is a bit of the end one, aren't they, really? For me, I would start at 4 weeks for everybody, particularly looking at the really good results we've had. Because what you're doing is you're just cutting down that whole year of having to look after that patient, try and get that wound healed. If we can shorten that right down, to a couple of weeks, what we've seen with some of those patients, the outcomes would be amazing and the cost save would be fantastic.
There was also a consensus document published in Wounds UK in March, I think it was, with Jackie Fletcher and a panel of clinicians, and they were looking into how to advise when to start Woulgan, and the advice is really where standard care is not working for the first 4 weeks, but also for high-risk patients, and that could be diabetics or other high-risk patients, when the clinicians know that this is a patient that probably is going to run into problem, it could be worth starting treatment from they actually arrive at the clinic.
Okay, so we've talked a little bit about when we start the product. When would you stop? Do you do it for 2 weeks, 4 weeks, 8 weeks till healing? What's your experience, views?
I mean, for me, if the wound's progressing, then I would do it to healing. Because what's the point in stopping something that's reducing the wound size, depth, etc.? You'd be foolish, wouldn't you, to stop it sooner? But I don't know whether there's clinically whether you have any guidance on that.
Well, we do know that the macrophages need some exposure to the beta-glucan. So we do recommend treating for some time, so at least 4 weeks, and then you can do an assessment if the wound is actually responding to the healing. And then if you see improvements, that could be the wound is cleaner, the healthier tissue, wound size reduction, obviously, then you can continue for another 4 weeks treatment. But of course, this isn't the treatment you should continue with for half a year. As you saw with the Hunt study, you still see 92% healing at 24 weeks, but the wounds were only treated for 8 weeks. So for the cost effectiveness, I wouldn't say you should continue for very long periods of time. But as long as the wound is responding, there's no chance of overdosing or doing anything else. So it's more the health economic that will guide you a bit there as well.
Okay. Anybody got any questions? Do you want to just come down to the microphone? I'll take number 3 first, and take you.
Sorry, I couldn't see you. Once you've opened the product, I don't know what it looks like, but is it stable to continue using for so long?
It's just single use for each tube. So it's a very small tube.
Right.
It's just single use, then you throw it away.
Okay, thank you.
You're welcome.
Hi, I was curious when you showed your negative pressure treated patients where you had full granulation tissue formation. And we talk about the macrophage, which really has done its job much earlier on in the healing process. Do you think the beta-glucan itself will affect other cell types at that end stage of healing to facilitate the closure that you saw, and not just focusing on the macrophage at that stage? There may be other effects it might have on the healing process.
Ingrid, do you want to take that?
Yeah, it's a really good observation, and it is. There are other immune cells that has these receptors that are recognizing beta-glucan, but it is the macrophages that are actually directing the healing process. So even if you have the granulation tissue, and that's, I guess, from Kim, you could probably vouch for that, sometimes you get the wounds into the granulation or proliferation phase, but it still stalls. And the granulation tissue can be really dull. So then you still have the healing process is sort of slowed up, and you still need to get it back on track. So by introducing the beta-glucan, you are able to reactivate or get the process going again.
So maybe through other cell types as well as the macrophages?
There are some other, but it is mainly the macrophages. Okay. And even if the macrophages are really central in the resolution of the inflammation, they are also important in the subsequent phases, as they are actually secreting these signal molecules and growth factors that are directing the other cell types and the processes that goes on in the proliferation and even in the remodeling phase. So they are crucial in coordinating the process, even at the later stages where there are other cells that are actually doing the job.
Thank you.
Thank you very much. Any further questions before we close down this symposium? No? Well, I can direct you to the H&R stand where you can, if you've got questions that you're too shy to stand up and to ask, then they'll be there straight after the symposium. We'll be there to answer any questions you may have about the use of the products in particular wound types, how it works, etc., etc. So if you want to come to the H&R healthcare stand downstairs, then we can answer your questions there. And I'd just like to thank our speakers in the usual manner for the fantastic presentations.